Good afternoon. I'm Angela Brown, a health communication specialist in CDC Center for Preparedness and Response, Division of Emergency Operations. Thank you for joining us today for EPIC webinar on Building the Bridge, Community Trust and Contact Tracing during COVID-19. Today we will hear from Mark Sendak, Michelle Krieger, Mary Gray, Andrew Herrera, Alexandra Valadares, Meredith Moore, and Julie Schofield. If you do not wish for your participation to be recorded, please exit at this time. You can earn continuing education by completing this webinar. Instructions on how to earn continuing education can be found on our website, emergency.cdc.gov/EPIC. The course access code is EPIC1209 with all letters capitalized. To repeat, the course access code to receive continuing education units in all caps, EPIC1209. Today's webinar is interactive. To make a comment, click the chat button on your screen and then enter your thoughts. To ask a question, please use the Q&A button. The Q&A session will begin after our presenters have finished. Closed captions are available for this webinar. We are fortunate to have our speakers with us today. Mark is a founding leader of the Pandemic Response Network and has helped to lead the program since March 2020. He has worked with interdisciplinary teams to develop COVID-19 support tools and programs, including collaborating with other individuals presenting during this panel discussion. Mark has worked in health innovation for 6 years, integrating numerous technologies into clinical care. Alexandra is currently a PhD student with the University of Vermont, working on leadership research in ecosystems. She worked with the Durham, North Carolina public school system to develop a support program for Latinx families. Her work in this area was instrumental in gaining her current role as a member of the Board of Education. Andrew has been a leader of Cure Americas Global since 2013 and has been responsible for leading the strategic initiatives, development of the board of directors, and the day-to-day operations of an international non-governmental organization based in Raleigh. Mary studies marginalized groups and their everyday uses of technology to manage health and employment. Her current role at Microsoft within research development has allowed her to share her subject matter expertise in this area to today's discussion. Michelle is a subject matter expert in human-centered design, health program design and implementation, and research and prototyping related to program improvement. She'll be using her expertise in this field in the discussion of today's webinar topic of building community trust during COVID-19. Mary is an experienced health communication specialist with demonstrated success in issues management, project management, partnership services, leadership support, media relations, website content management, policy research, training development, and program implementation and research. Julie joined the CDC Foundation in June 2020 to direct a project, the Community COVID Coalition, designed to help states educate and increase acceptance of contact tracing in their jurisdiction. She has extensive experience working with HHS, CDC, state and local health departments, and community-based partners to advance evidence-based solution to HIV, AIDS, and hepatitis. Thank you for joining us today. Mark, please begin.
Thank you, Angela and team at CDC for the opportunity to present today. We're particularly excited to be presenting to a group of community partners, which I think you'll hear throughout our discussion is a part of what we're doing. So I'm thrilled to be here with a team that's interdisciplinary, as Angela mentioned. So before we start, we want to ask some quick questions to try to level set with the team of folks that are participating. I don't know if folks can use the chat function, but we're just going to ask some basic yes or no questions. So if you want to answer just yes or no as we go through these. So the first question is, has your team or organization had to expand the scope of programs that you run to support the communities that you serve? Looks like yeses mostly. Second question, Has your organization had to take on new roles and responsibilities in your communities? Third question, has your organization gotten involved in contact tracing? Many saying yes. Interesting, just starting. Next, has your organization started to provide COVID-19 related health service? Yes. So even I think a group of organizations that may not be traditional health providers getting involved more aggressively in healthcare, which I think is what you'll see in our experience. Next up, has your organization cultivated new partnerships with private or public institutions? Yes, and everyone we're here talking with as part of our presentation, these are new collaborations. And the last question is, has your organization cultivated new partnerships with grassroots groups in the communities that you serve? Some mix. Okay, so thank you for participating in that with us. I think what we're hoping for this to be an engaging discussion. So as Angela, she kind of gave an overview of some of our roles. Today we are going to talk about community-driven approaches for COVID-19 support, specifically trying to reach historically marginalized communities. So one of the themes of our discussion is that we have folks who represent grassroots groups and networks of organizations of community-based and faith-based groups that serve historically marginalized communities. So first off, Alexandra, if you can just give a quick background of yourself and your work prior to COVID.
Hi, everyone. My name is Alexandra Valladares, and I live in Durham, North Carolina. I am a community organizer in this lovely city, and it has been a joy to lend my support to grassroots organizing, parent leadership, the kind of organizing that community members do to resource among themselves, and also to bridge gaps and reach out to institutions as well for support. It has been a joy to make these connections, to center relationship, to center a sense of personhood, belonging, safety, and joint responsibility for how we carry out things and how we ensure that communities thrive. So I am currently serving on a board of education, and during this pandemic, we have been having many conversations about how to best support families, and I'm really glad to be here.
And we'll be hearing more from each of the presenters. So Andrew, quick background on your.
In a nutshell, Cure America's Global is a nonprofit historically working internationally in community-based health to save the lives of moms and children, focused on really frontline or last mile health work in vulnerable and forgotten communities globally. In 2016, we decided to bring our mission home. In March of 2020, we scaled up rapidly to work on communities here in North Carolina.
And at another level, we have folks like myself and Mary who work within large institutions, Duke and Microsoft. So Mary, quick background on yourself to tee up the discussion.
Sure. Yeah. So thanks everybody for coming today, and it's exciting to be with this group of people. Most of my work is as an anthropologist, studying what people's everyday uses of technology are. I've worked in Southeast Appalachia in the United States and throughout parts of India, mostly in urban centers. And it's most of my experience is understanding what is it that people are trying to achieve that has nothing to do with the technology, and they just reach for whatever technologies are handy. And I'm bringing the most recent research I did on workflows. What are the ways we could build technologies that support and keep at the center people's work needs and the demands that come from their personal lives in balance.
And a different perspective we have today is actually from an evaluator and a designer, IDEO.org. So Michelle, quick background on yourself.
Great, thanks Mark. Thanks everyone for being here. It's great to be with this group. I'm Michelle Krieger. I work at IDEO.org, which is a nonprofit design and innovation organization. And what we do is we work directly with communities to really surface what are the needs either that they are articulating or that are under the surface, and then take those learnings to translate it into what program design could look like, whether that be communication materials or workflows to Mary's expertise, or ways that we structure programs to be better in service of people's needs. It's great to be here.
Thank you. Azam, if you could pull up the slides that we have, we're going to just show some visuals before we dig into the first set of questions. So these are concepts that IDEO helped us surface as we were thinking through how to do this work. Next slide. And the concept being that a lot of what we're trying to do is actually empowering and bringing up to the surface, as Michelle mentioned. So first off, we're going to be talking with Alexandra. So Alexandra, her activities with the program have really helped elevate the work of grassroots groups that serve historically marginalized communities. I think we're good on slides before we jump into this first question. Alexandra, can you describe your work before COVID-19, organizing in Durham?
Yes, you know, a lot of this comes from being rooted in this community. I graduated from Durham Public Schools and, you know, navigated a lot of hardship even as I was coming up as a student who like English was my second language. And so understanding a lot of the complexity of how communities are struggling to navigate systems, it became really important for me to, you know, as I learned things, to share the information and to reach out to other folks. As a parent, I have done the same thing, reaching out to other parents, and have found it really wonderful to organize. We've organized around language access. So in our city, the immigrant population is growing. It's been really wonderful to, you know, speak to city leadership, to county leadership, school board. Even before I was on the school board, I was advocating with other parents for language access, for information, for access to information. And so a lot of that work was about advocacy. It was about making visible what may not be at the forefront of many people's considerations, for how services are delivered, for how information is shared, for how connections are built, and whose voice counts. You know, so a lot has been about, you know, amplifying voices, and ensuring that we do keep in mind that you know, a community can only be as strong as, you know, the way that we serve all community members. So if we have a marginalized group, if we have underrepresented, if we have disenfranchised community members, that community is going to be hurting. And so looking at ecosystems, looking at networks, looking at the ways that we all thrive, it's by doing it together. It's by ensuring that we are meeting the needs, and rising to the challenges of diversity, and the riches of diversity. So making those connections. I think that my work prior to COVID really let me know the importance of building relationships and of trust, which is what this webinar is about, and how that trust comes from taking time to listen, and taking time to listen more, and taking time to do even more listening intentionally, to understand, you know, what are the things that matter, what are the most important things that communities are saying are important to them, and also how to navigate those relationships. What are those relationship protocols that we need to be mindful of as we approach folks and as we try to help? You know, are we coming from a top-down level, or are we building with people? Are we building, designing? Are we really doing a collaborative effort, or is it more of a assumptions and top-down? So a lot of those conversations have been a part of my organizing prior to COVID. Not just around language access, or, you know, even navigating school system or even the city, but it's also been about healthcare as well. So a lot of wonderful connections that have come from that, and a lot of parent leadership that has been budding since then. You know, a lot of parents are helping the city navigate transportation challenges, including, you know, transportation for the future. What is that going to look like? So many wonderful conversations around engagement, around, you know, green space, around many city things, around education. And I think that this is this work that I've done before COVID has been instrumental for many folks, including myself, to have a seat at the table. And I'm the first Latinx board member that we have in our city. So really grateful for the support of a community, and also to lend insights to as many folks as want to hear about the experiences of marginalized communities.
Alexandra, you started to speak to it, but how have you seen the role of grassroots group change during the pandemic?
I think that during the pandemic, the grassroots efforts have been they've been instrumental. They've always been there. So it's interesting. Like when, we have the image, when we had the slide of the roots underground, like what is happening underground, right? There's a lot, and sometimes we miss it. But in the case of grassroots, I mean, grassroots have been sustaining. The grassroots have been, meeting the gaps in terms of access to resources. Many grassroots organizers have been doing this work for decades in Durham, and we have learned from each other. Some of those efforts are even meeting like hospital bills, like how to pay certain healthcare costs that some members of the community don't qualify. They don't have insurance, and so how do you navigate those constraints? And it's been about like grassroots efforts with fundraising, grassroots efforts of resourcing from among families. A lot in terms of speaking to leadership about what matters and what are some of the concerns, including things that there may be things about privacy. There may be things about like policies that are in place that unless you have that lens, unless you have that experience, you wouldn't know how it affects or impacts people. But then, folks who have been on the ground, who understand how policies can impact them, they will share that. And I think a lot of this has been about grassroots organizers and parents who are coming together, speaking about their experiences and helping leaders, modify policies at times, or sometimes even implement new ones, and adding more layers of support because of those conversations that are very important.
And next up, we're going to go to Andrew from Cure Americas. And I think what's fascinating here is that Alexandra has been deeply involved in our efforts in Durham, and the group that we're working with even spans outside of Durham. Andrew has had to quickly kind of approach this at the state level and how to scale up these programs across communities. So Andrew, how did Cure Americas quickly scale to run these types of community-based programs in counties across the state of North Carolina, which for folks who don't know, 14 million people, big state?
Yeah, thanks, Mark. And I think the reason we had to be here is because we saw at the beginning so much health information coming out, not in Spanish, and not reaching the people who needed it most, who are often forgotten and vulnerable. And so that's the values of Cure Americas in our group here, is including everybody from the beginning. And Alexandra mentioned grassroots, listening and more listening. It's so important. The way we were able to quickly scale is through community-based organizations, through grassroots organizations. And so Cure Americas is partnering today with 20 separate independent CBOs, community-based organizations. They were here before Cure Americas. Most of them were already doing work related to, for example, a food pantry or outreach in their community. They didn't have the funding and the support. They were still independent, not part of the system. And so Cure America's vision is long-term partnerships where we are working inside of a system and strengthening that system. And so through these grassroots partners, we were able to quickly scale up to 180 full-time community health workers. 95% are people of color. Over 50% speak Spanish. They look like the community that they're serving. They're from the community that they serve. They speak the language, they sit and they eat and they pray and they stay with the community. And so they have natural trust. Of course, it's not the end all, but it's the important step. It's not Andrew going into a community and saying, here's what we think you should do. It is working with communities for them to establish their own protocols and procedures through their own community health workers.
And Andrew, the role of Cure Americas as being somewhat of an intermediary between the state, community members, local departments of public health. What do you see as the role of that? Why is it critical both during the pandemic as well as after the pandemic?
Sure. I think that I've been thinking a lot about this recently. Like, what's the value added of Cure Americas? Why are we here? Right. And so we have some values and vision for what health looks like that we think is important, which is why we're here, building trust and working from the bottom up. I think that's critical. I think we also are, as a managing organization, we're able to check all of the regulatory boxes that federal or state dollars require, or big donors are requiring, related to auditing and accounting, financial management, but also quality, data, evaluation. There's so many regulatory burden that comes in this work in the healthcare space that you're all familiar with. And many of the last mile implementers, the community-based organizations, the church on the coast, that is an awesome community-based organization, but they have never had an investment in their capacity to check these regulatory boxes. And so the donor often is unwilling to risk a big investment in a grassroots organization. And so Cure Americas takes that risk on, but we also ensure quality and provide support. And each of our partners across 26 counties and 180 community health workers looks different: urban and rural, Black and Latinx, food and social services and wraparound services and schools. They all look very different, and their context looks different. And our environment changes day in and day out. The state, our biggest donor, North Carolina Department of Health and Human Services, is wonderful. Every hour there's an evolution happening. We see that in the news today. And so how do we keep up? And so Cure Americas is serving as that bridge to the donor, from the donor to the grassroots organization. But we're also doing, context specific capacity building. So you're, as an institution, you have really strong fill in the blank capacity. What can we do to help? Okay, you need more accounting support. We can help you with that. Or you need more monitoring and evaluation and data support. We can help you with that. Or you need some sort of technology that we can build with you. So it really is so context specific and so localized, right? It's really about listening from the bottom up. And often large donors don't have the interest, capacity, the ability to do that type of hand-holding or support with partners. And that's where Cure Americas is saying that's our priority. And so as we invest long-term with partners, it's not just a one-off. We're hoping to build sustainable institutions, sustainable community-owned institutions. Of course, health is at the forefront of that, but behind a community health worker is the accountant, is the project coordinator, is the monitoring evaluation, and so many more things that support that community health worker to be effective. And that's where Cure Americas is coming in to be that bridge.
And so for folks who don't know me, I've built relationships with Andrew and Alexandra over the last 6-7 months, clearly inspiring individuals at the forefront of this. I sit at a place like Duke, a very well-resourced, established organization. And so we're going to shift gears a little bit and talk about how established, well-resourced organizations can amplify the type of work that's happening at the front lines right now during the COVID pandemic. So we're going to go next to Mary. Mary, can you describe your role helping technology developers and public officials navigate both the pandemic and all of the eagerness to deploy technology solutions to problems that states, localities are facing because of the pandemic?
Yeah, so a large tech company like Microsoft or any of the large tech companies that have jumped in and really driven as much as they can ideas that they feel are the best solutions are the places where I try to sit quietly next to my colleagues and say, maybe, and often I'm whispering, but this time I'm yelling, maybe this is a good time for us to just slow down and listen. So I really want to lift up something Alexandra particularly said about being able to go to large institutions like Microsoft Research or to enter conversations at Harvard University where there's a digital pandemic working group and to be able to be in those settings and remind everyone we are starting with a set of assumptions about what technologies can do. So my most important intervention from the training I have is to surface those assumptions, to be able to see institutions that want to help, particularly large, well-resourced institutions that have biases about what help looks like, often need to slow themselves down and, more importantly, pay attention to other interlocutors, listen closely to people who are much closer to the problems that need to be solved. So that's the particular intervention that I'm trying to bring. And I also try to inform the California Governor's Council of Economic Advisors on how does addressing the pandemic's health needs lead to a way of thinking about work and our economic recovery, because they're very much hitched together. So I feel like I have a sense of what it looks like to fight that fight within my own institutional context. I want to ask you, Mark, what do you think your role at Duke affords for you as a place to buttress or boost the pandemic response network?
It's interesting, Mary, because I feel like there were some things that we were very quickly able to leverage based off of expertise and capabilities at Duke, such as we have protocols that we're using with our health workers. We're building tools to support the reopening of our campus. There's a lot of expertise. My team, we've done a lot of health innovation product development. We can quickly enter new settings, understand workflows, surface problems, build workflow solutions. Where we struggled was reaching those hard-hit communities. To Andrew's point, that last mile, we stood up our programs run out of Duke with Duke volunteers for our community, and 90% of the participants were white, even though 80% over the summer, up to 90% of new COVID infections were with the Latinx community. So it forced us to enter new spaces and new partnerships. And Mary, turning back to you for a second, we originally met in the context of AI and building these aspirational technologies, algorithms, high stakes decision making. And with any technology, there's a gap in the aspiration and what is currently there and available to solve problems. What do you see as kind of the biggest gaps and most concerning in terms of how we think that these solutions can work?
I bet there are a lot of people on this call who can relate to feeling like technology companies or other well-resourced companies came to them and told them what they should use or do. And I think the biggest gap is that, particularly in the United States, we started out with a set of assumptions about what were the most pressing problems that needed to be solved. We didn't really tune in quickly to think about the four pillars of fighting any pandemic: being able to test people, being able to trace who they've been in contact with, but the last two pillars, being able to identify how to monitor and support patients in need, and then finally helping people quarantine. We quite literally, within the tech sector, thought the most important thing is to develop an app so we can insulate and protect healthy people. Everything we need to change now has to do with building systems that build trust and build out technologies that support caring for sick people. So, the most troubling gap is that we've known for months now that the pandemic is disproportionately killing people of color. And we haven't moved to, or rather out of, this abstraction that the pandemic is everywhere, present to everyone. It's certainly circulating everywhere, but it's disproportionately hitting the hardest people whose occupation puts them at risk because they're supporting everyone else, people who have health risks already. So there are places where bridging the gap has everything to do with accepting and grappling with the systemic inequality that is the landscape of the United States and the complete absence of most public healthcare systems in the communities most in need. So for technologists, the tough lesson is that you never want to deploy technology that sends a text message about something that might have killed someone in your family. That's nonsensical. So the ground we have to make up is focusing on how would you equip people, particularly community healthcare workers embedded in their communities, with the resources they need to build continuing, ongoing support of people they want to care for in their communities with the right linguistic fluency, cultural competencies, and trust, so that people who do not feel comfortable coming forward have someone safe to connect with. That's the road ahead of us. And I actually am quite optimistic if we can move the energy we've spent on notification apps into a much more robust approach to supporting people like Alexandra and Andrew's community and network, that will be in a much better place to build out the public healthcare infrastructure we really need. I'm curious for you, Mark, like how do you think about the iterations here with technology and programming? Like how do you bring what you're learning from your partners into building out these systems that you want to scale?
A lot of the listening and adapting, and the biggest pivot was going from the centralized Duke program to working more directly with the Alexandras in the different communities and identifying those people, empowering them, empowering the groups with Andrew's support as well with Cure Americas. When we talk about new systems and building for the future, I think I want to shift to Michelle Krieger and her team at IDEO. So they've been really boots on the ground studying the work, observing it, talking to folks as we've been building the ship. We've been building the ship, financing the ship, sailing, and Michelle's been pointing out the holes and where there's water, that next wave that's going to come over the edge. So Michelle, can you describe your experience working with this group and how it's evolved? And I'll try to just bundle the questions and what you see as the key lessons to share.
Yeah, definitely. Thanks, Mark. I love the ship metaphor. One of the metaphors that we've been playing with as a team as we sort of observe and help co-create and build this ship. We've been playing with this metaphor of Cure Americas as an air traffic controller, sort of sitting between the CBOs and the on-the-ground organizations that are really doing this work, and helping to play kind of a translator, a coordinator, an ease sort of role with connecting into funders and to the state and to more well-resourced organizations that are helping to stand up this effort. So don't know if that will stick, but it's something we've been thinking about. You know, in terms of our experience with this work, Mark and I connected really in the early days of the pandemic, at the moment that Duke had just begun to stand up a centralized program. And part of our work in those early days or weeks was really to help surface what it could look like or what might need to be true in order to expand from something centralized to something that is really owned and held by the community. So in that first phase of work that IDEO.org did with this group, we surfaced sort of a set of insights or learnings through engaging with communities that help to kind of steer and set almost the foundations or the principles of what this effort might look like. So some of the insights that came out of that work were, they feel intuitive to me as a designer that's focused on human needs. So trust comes easier between people with shared language and culture and experiences. For many in this moment, caring about COVID almost feels like a luxury. There are many other things happening in folks' lives, and this is one of the many stressors and challenges of the moment. I think we've talked a bit about technology through Mary's contributions here. I think we're seeing that there is much to do in helping to surround or put scaffolding around that technology that feels safe and that feels trusted. And finally, that there is, there's a real need to connect into someone that you know, and that you're much more likely to change your behaviors, to feel comfortable, to feel confident, to feel supported, if you are engaging with someone that feels familiar to you. And so that work happened in March or April. And since then, you've all heard now a little bit about what this team is collectively doing. Our work now is really to take a moment to kind of step back and look across this work and to highlight where there may be opportunity for shifts, and also what feels like it's working really well. So a few of the methods we're using to do this, we've been conducting sort of like day in the life diary studies with community health workers, where we equip them with cameras and WhatsApp feeds, and we just have them really share what is the experience day to day, hour by hour of doing this work, in service of building empathy, but also in service of telling this story in an authentic way to the communities that need to hear it. We've been interviewing stakeholders across the health system as well as CBO leaders. I think we're seeing that there's so much opportunity in this model. First and foremost, I think the needs, one of the most pressing opportunities that we're seeing is, as Alexandra and as Andrew have already shared, there are folks out there already doing this work. And so part of our opportunity as organizations connected to those that are more well-resourced, to funders, is to prioritize paying those who are already doing this work, and to not assume that the lights will be on next time there's a crisis, right? Part of our role is that we are seeing, and what's emergent in this work is that the community health workers, the CBOs that form the backbone of this effort, are almost kind of emerging as an extension of the public health system. And so the opportunity there is, how do we treat these organizations and these individuals as such, and really lift them up and lift up their perspectives in service of helping us to build something that is more inclusive and that meets the needs of the people that are being hit most hard by the pandemic and by the challenges of this moment. I think one more thing I'll call out is, I think we're just seeing the power in a role of Cure Americas to serve as that intermediary. It's incredibly difficult to figure out how to navigate the structures of funding, the structures of power that exist in the healthcare systems, in the in governments at a state level, at a regional level, and often it. I think one of the biggest things we're hearing from the CBOs that are working with Andrew and his team is just that almost like shielding is quite useful, and that connective tissue that Cure Americas is playing between the CBOs and the on-the-ground individuals and institutions and those that are resourcing, really wanting to see these outcomes, that is invaluable. And I think we often undervalue that intermediary role. And so perhaps for this group, something to think about is like, who are the Cure Americas in your state, in your region, and like, how can we better leverage those institutions to provide a shielding role, provide a connective role, and to really shift power from where it is tightly held to organizations on the ground.
And for me, this has been an incredible group to get to work with. I view this team as part of the Power Rangers that have been in the trenches, each bringing different perspectives. To just close out from what Michelle is saying, I think that what's been really interesting here is how the pendulum has swung. Early on, I think we realized collectively the need for some practices that seem normal from global health settings. Folks like Andrew, folks like Michelle, community health workers, accompagnateurs, doing this work in North Carolina. And now I see a lot of what we're trying to do is take these things that we've refined locally, and how do we take that beyond North Carolina, and how do we take that to other parts of the country. So we are going to address some of these questions at a Q&A session at the end. Thank you, everybody. And I think that's the closeout of our session.
Hi, good afternoon, everyone. Thank you for the opportunity to be here with you today. I'm really excited to be a part of this conversation. My name is Meredith Moore. I'm the communication team lead for the Contact Tracing and Innovation section on CDC's State, Tribal, Local, Territorial Support Task Force. Today, I'm going to present to you an overview of the resources that CDC has helped to develop to build community trust in contact tracing. Next slide, please. So since the beginning of the COVID-19 pandemic, many states have faced a number of different obstacles as they've worked to build their contact tracing workforce. The success of contact tracing programs depends in large part on the community's level of participation and acceptance in contact tracing. There have been mixed messaging across media outlets during the pandemic, and that's highlighted both the benefits and the obstacles of contact tracing. So for example, on May 19th, 2020, you can see here on the slide, the Federal Trade Commission issued a statement informing the public about reports of COVID-19 contact tracing text messaging scams. One of CDC's key strategies is to provide information and resources through social media. Comments on CDC's social media messages have generated a mix of positive and critical comments across our social media platforms. Some common challenges for public health professionals around contact tracing continue to be mistrust, apprehension, and privacy concerns. To address these concerns, CDC works to promote trust in the public health department and dispel misconceptions about contact tracing. For example, many of CDC's contact tracing infographics, web pages, and other resources feature consistent messaging that address these privacy concerns. This helps to build community trust and awareness about contact tracing, as well as to dispel these myths and correct any misinformation. Building trust is a key component of effective community-based public health, particularly for case investigation and contact tracing activities. Next slide. To help generate understanding and acceptance of contact tracing, CDC has developed and continues to develop new and engaging resources about contact tracing for the general public and health departments. One of CDC's first resources that was created on contact tracing for a consumer audience is the contact tracing webpage, as you can see here on the slide. It was initially published in June 2020 and has since been updated as CDC's response to COVID-19 evolves, and we continue to learn more information about the virus that causes COVID-19. The webpage here defines contact tracing and provides an overview of what the steps are involved during the contact tracing process. It also highlights what someone who is diagnosed with COVID-19 can expect to happen during contact tracing. To help promote trust and dispel misconceptions about contact tracing, we highlight what the health department staff will not ask for during their conversation with someone. So you can see it noted here in yellow on the slide. You'll notice this messaging in several different places on the CDC website just to help reinforce that message. This webpage here has been translated to Spanish, Chinese, Vietnamese, and Korean to help reach a broad audience. Next slide, please. So in addition to the consumer webpage, we also have a frequently asked questions webpage on contact tracing. These were originally posted to the main CDC FAQ webpage in June, and since then we've added more questions and answers to address any new and emerging topics on contact tracing. Again, highlighted on this page is what the health department staff will not ask for in their conversation with a person about contact tracing. Next slide. The contact tracing communications team developed this contact tracing infographic for a consumer audience to clearly explain contact tracing and case investigation. This is just one of several materials that the team has developed to help combat the misinformation that continues to circulate about contact tracing, the privacy issues, and any other concerns. The first page on the left outlines what you can expect to happen during contact tracing if you've been exposed to someone with COVID-19. In other words, the case investigation process. The second page on the right lays out what to expect if you've been exposed to someone with COVID-19, which is the contact tracing process. To build trust and confidence in the contact tracing process on both of these pages, the first circles on the top of the page with the red text. It's kind of hard to see in this image, I think, but it provides an overview of anything that you tell the health department is confidential and that your personal and medical information will be kept private in those conversations. The infographic is available for download on the CDC website, and it's available in English, Spanish, Chinese, Vietnamese, Korean, and Marshallese. The images that you see here in the infographic have also been adapted to be culturally appropriate for target audiences. Next slide. So in addition to creating web pages, fact sheets, infographics, and social media messages, we've also created a 1-minute video that informs the public about contact tracing and why they should answer the call from a contact tracer. The video, as shown on this slide, explains the process and what to expect from the call. You'll also notice that the statement about what the health department will not ask for during their conversation is also highlighted to reinforce the message. Azam, will you please play the video?
Contact tracing helps keep you, your family, and your community safe by slowing the spread of COVID-19. Contact tracing lets people know they may have been exposed and what to do next. During contact tracing, you will never be asked for money or a social security number. Your information is safe. If you have COVID-19, a public health worker will call to check on your health, answer questions, and let you know about services that could help. This information is confidential and kept private. The public health worker will also ask you where you've been and who you may have been around. These people are your contacts. The public health worker can help your contacts find testing and learn about symptoms and how to keep others safe. To slow the spread of COVID-19, answer the call from public health workers. Learn more at cdc.gov/coronavirus.
Thanks, Azam. So we have this video available in English, but we're also working on having this translated to Spanish, and we will be posting that on our website soon. The English version is available on the CDC COVID-19 website. Next slide. In addition to the resources that we've created for the general public, CDC has also created resources specifically for health departments to help them in conducting case investigation and contact tracing, as well as communicating with their communities about these topics. For example, CDC has created guides to provide suggested communication strategies, approaches, and steps for public health staff and contact tracers to tell people that they may have been exposed to COVID-19. CDC has created guidance documents, trainings, and resources to help implement contact tracing that are all available on the CDC COVID-19 website. One important resource that CDC has created is the COVID-19 Contact Tracing Communications Toolkit for Health Departments. This resource is a plain language resource that contains messages for health department staff to clearly and effectively communicate with their communities about contact tracing. The toolkit has sample talking points, public service announcements, graphics, social media posts, and questions and answers to help their staff and their community communication strategy. This slide here shows 2 examples of the graphics that CDC has created, and there are also many other options available for download on the website. Next slide. Social media platforms are an important part of CDC's communication strategy. This slide here shows an example of a contact tracing Instagram story that was posted to CDC's account in June 2020. If you're not familiar with Instagram stories, they're a popular way for users to post videos and photos that disappear within about 24 hours of being posted. CDC saves all of the COVID-19 story content in the Stories Highlights feature so that users can access the posts after 24 hours. Instagram's audience skews younger than most platforms, such as Facebook, so it's a really good opportunity to get in front of a key population. This story encourages consumers to answer the call from their health department, and it walks users through what they might expect if they're contacted about a potential exposure to COVID-19. As you can see here on the second frame, we again highlight that any information that's shared with the health department is confidential. The original Instagram story was shared as a Facebook story as well in June, And when they were posted together, they reached nearly 1.5 million users and received almost 500 shares. The images in the story here, they were diversified and also added to the contact tracing communications toolkit for health departments. The diversified images have since been used in other social media posts on a variety of platforms, as you'll see on the next slide. Next slide, please, Azam. CDC continues to hear reports from health departments about the challenges in gaining public acceptance and trust around contact tracing. To address these concerns, CDC continues to develop resources for the general public, healthcare providers, and health departments. As shown on this slide, CDC highlights contact tracing resources and information on our social media channels. While the social media posts do receive negative comments, there are also many positive and supportive comments on this post as well. To build community trust, we must continue our efforts in providing clear and accurate information when it's available. So please be sure to check out all of the mentioned resources here on the CDC COVID-19 website to use in your organization's communication and education strategy. Thank you, and I'll pass it over to Julie Schofield from CDC Foundation.
Good afternoon, everyone. I really want to thank CDC for the opportunity to join this webinar this afternoon. And I think my presentation is going to dovetail nicely with Meredith's. Next slide, please. So I'm here to talk to you about a project of the CDC Foundation. If you're not familiar, the CDC Foundation is a 501c3 nonprofit foundation. It's unique because it is chartered by Congress, and its mission is really to support the mission of CDC. That's our name. And so the foundation really supports ongoing way the work of the CDC and has been incredibly active since the beginning of the pandemic, trying to mobilize resources and fund activities in the response across the country. So I'm here to talk about a really special and unique initiative that started in June of this year. It's an initiative of the CDC Foundation with partnership with the National Governors Association and the Association of State and Federal Health Officials, called the Community COVID Coalition. This is a unique public-private partnership because the idea for this project really came from Facebook. Facebook approached the foundation in the spring wanting to support health departments. And in particular, they wanted to, Facebook wanted to support health departments advance their contact tracing programs. So that we knew at that time that health departments were trying to build surge capacity and hire contact tracers. We knew that contact tracing was going to be a key element in the COVID response. And so the foundation and Facebook partnered, bringing on board NGA and ASTO to create this project, which is designed to support contact tracing through the development of targeted social media assets that then we would make available to all the states, and the states could use these resources on their Facebook and Instagram pages. And again, the key idea here was that we could reach key and targeted audiences and enhance trust and acceptability and basic information about what contact tracing is. Next slide, please. So to begin with, we knew that we needed to conduct some research, and we were charged with developing these campaign resources and assets. And so we simultaneously, because we're in a very rapid timeline, conducted some research to understand the landscape of awareness around contact tracing, attitudes and beliefs, identified barriers. We did this research at the same time that we were also rapidly developing creative assets and testing 2 particular campaigns for moving forward. The research project was undertaken by Social Quest and led by Dr. Monica Torres. This research that was conducted is available on our website, and I'll be citing that a little later in the presentation. But I highly recommend, if you're interested in really looking at some of the barriers and concerns that people have about contact tracing, that you look at the research that Dr. Torres and her team conducted. It was very fast but rigorous, They segmented 6 different populations of people highly impacted by COVID-19. They did focus groups with actual contact tracers to understand a little bit better the process and what contact tracers were facing out there as they were conducting their work. And so again, that research is available on our website, and I really highly recommend folks take a look at it. At the end of the day, we selected a campaign, and similar to CDC's, our campaign was called "Thank You for Answering the Call." The campaign assets are available in Spanish and in English, and they include 30-second videos, animations, statics, infographics. Our creative team included GMMB and Toolbox 9, and all of these assets are now available to states. We're going to keep trying to add to our library along the way, but on our website, all of these assets are available. Next slide, please, Osmo. So then what happened? We did the research, we created the campaign, and then we invited all of the states to participate in the project through our partners, NGA and ASTO. So governors were contacted by the National Governors Association, state health officials from ASTO. We've sent out reminders, we've done some targeted research. This all happened at the end of September, early October, inviting all the states to take advantage of these assets. Now, the key thing, which I haven't really focused on yet, is, well, what's the added benefit? The added benefit is that Facebook is providing free ad space to the states that come on board. So not only have we created these assets on contact tracing for states to use, Facebook is going to provide free ad space in the form of donated ad credits to each of the states that come on board, along with some assistance from one of their marketing partners so that the state campaigns can be really customized. You can put state logos on them, you can change some of the graphics in them and make them your own, including how to target them best in particular regions of your state if you're interested in doing that. All the states have to do is let us know that the governor or health official have approved of the participation in the project, identify a lead point of contact, and send us an email. We then immediately connect the state to our points of contact at Facebook. And the first thing they have to do is go through a very streamlined kind of compliance process that really just entails making sure that the state is legally able to accept donated ad space from Facebook. Following that compliance process, we'll get connected to the marketing partner and the targeting and customizing of the campaigns happening. Next slide, please. So the other fun thing I think for states is that you don't have to start running these campaigns immediately. If there's too much going on right now, and we know that there are COVID fires all over the country right now, it might not be the best time to be really focusing your energy on educating the public about contact tracing. States can decide when they want to run the campaigns. So they can come on board, go through compliance, find out how much donated ad space they're going to get, and then hold on running the campaign until the time is right for them. Once they decide and that clock starts, they have 90 days to run these campaigns. And we're really excited that we think the first round of campaigns are going to be airing next week or the week following. So far, we have 16 jurisdictions that have joined the coalition. And there are several other that are in conversation. And our hope is that all the states will take advantage of it because, again, it's kind of a one-stop shop situation. You come to the coalition, we connect you with Facebook, you'll get donated ad credits, and then you can pick and choose from our library of assets what you'd like to run. The other thing for this audience this afternoon is that all of our creative content is available on our website. It's owned by the CDC Foundation. We're making it publicly available. So if there are any of the statics or other pieces of information there that you think your organization might use, you can download and use it. We're making that available to everyone. So that's kind of it in a nutshell. And next slide, please. There is our email, covidcoalition@cdcfoundation.org. And I really hope and encourage you to take a look at our website, covidcoalition.org, and take a look at the research, take a look at the assets, and always feel free to contact me if you have any questions. And on that note, I'm going to turn it back over to Angela. Thank you, everyone.
Thank you so much, Mary, and all of our other presenters. Now we're going to transition to our Q&A session. Jonathan, would you read the first question, please?
I will. I want to encourage everyone, if you have any questions right now, to go ahead and put them in the Q&A section. And there's some we already answered that we're going to go back and answer live as well. But I would like to start off with a question that is kind of a summary from two different questions. Given the large number of cases and limited resources, can you comment on how contact tracing can be useful this far into the pandemic? And if everyone's waiting for somebody else to answer first, I'm looking at Meredith, and I'll say, Meredith, can you comment on that first?
Sure, I'll respond to this first. So we do understand that many different areas of the country right now are strapped because of the increase in cases. On November 23rd, CDC released a new guidance document on how to prioritize cases for contact tracing. So these new recommendations, they further refine the existing prioritization recommendations, and they present new modeling data so that health departments can use that information to maximize the effectiveness of their contact tracing efforts. So we do encourage folks to visit the website. If you don't know about these new guidelines, I can type that link into the chat, but we hope that that will be a helpful resource to folks.
Great. And Mary, you had an interesting comment on this as well.
Yeah, I think, what do we know in epidemiology about the application of contact tracing? We know it's really, really effective at the very beginning of a pandemic so that you can get in and identify and effectively corner the disease. So that's not where we are in the United States. What we could do is rethink, what do we do with contact tracing? Rather than treat it as a way to find out a list of individuals, treat it as the beginning of a conversation that's an ongoing conversation between a community healthcare worker and an individual who's embedded in communities who are likely at high risk. So we could picture moving contact tracing out of the business of having a contact sheet and into the business of, think of it as preventative care, where you're effectively building out health communication messaging that has a specific messenger. That would be my thought on what we could do with contact tracing today.
Mary, I do want to extend that because I know that Andrew, he has been called upon by the state to start to serve in a different capacity. And I think it's really neat in the state of North Carolina how we started with community empowerment through community health workers, and now the role is changing. Andrew, if you want to speak to that and the vision of what we're doing in the state.
Yeah, that's exactly right. Thanks, Mark, and shout out to your daughter, newborn dad. Love it. The state of North Carolina has been thinking innovatively about this for a while, and that's why we have the CHWs on the front lines, paid for by the state and combined with other funding. And it may not be true for every state, and that's something we're looking at, how to scale this. But a new thing that came up is, okay, what do we do for funding beyond December 30th or beyond COVID? And so it's all about building up this workforce, building up these frontline, trusted, embedded community members to join a public health system and to be part of it. And so 180 community health workers in North Carolina have checked the box to be trained as contact tracers. They've spent over 15 hours of asynchronous training today in place, ready to go if they need to be. And to Mary's point, when you make that phone call, what else can you do? What else can you take advantage of that opportunity to not just say you're in trouble or you might have to, isolate and quarantine for 14 days. Instead of bringing bad news, bringing good news also you have this exposure, and here are some answers, here are some solutions, here are some resources from somebody that you trust, who's going to not just call you once, but follow up and be an ally to walk with you. And so that's active right now. So I appreciate that question.
And Andrew, just going off of that for a second, I had a fascinating conversation with Alexandra a few days ago. So North Carolina on Thursday announced phase 1 of the Abbott Binax Now rollout. So these are the rapid antigen tests, 150 million of them purchased by the federal government, rolling out to states. We were talking with our local public school district, and there was concern over what type of capacity is there within the public schools to train rapidly people to conduct these tests. Are folks familiar donning and doffing the PPE to do this? And Alexandra and I were talking about, well, is this something else that we could put within the wheelhouse of these trained, ready to go personnel who have the trust of families, the trust of parents? And I think we're only seeing the tip of the iceberg once you have these networks built and you start to get the expertise that's typically centralized in a place like Duke out in the community, the way that you can bridge these gaps. And Alexandra, if you want to speak any more to that in the
Yeah, I mean, I've seen a lot of empowerment with parents. I mean, I think, we think about impact, we think about, I know that there's the individual and there's the community, and, we start looking at the whole network. They're moms who are in apartment complexes. And once they have been trained as community health workers, they are effectively informing and also modeling and providing resources for an entire apartment complex. And that's one of many, right? Like wherever they live, the leadership capacity building of community health workers, empowering them with information, giving them opportunities to be a part of our health, of our health care, as in like the care that we provide for all community members. I mean, it's very impactful. And like Andrew said, there's some of them who are community health workers who are now also being trained to be contact tracers. And that is also helping us in the schools, the level of support that our schools need. We need empowered parents. We need parents who have information. So definitely it has been beneficial. I've seen a lot of parent organizing by school building at a building level, where there's somebody there who is either a contact tracer or a community health worker, who is learning, and also even learning about research. They're coming up with many different resources that they're providing. And so as we are looking at development, and we're looking at how communities thrive, I mean, there's a conversation that needs to start with including folks, and empowering folks and giving them the best resources and information that we have.
If I could just add one more thing to this important topic of the role of the community health worker and the trusted community-based organization, what we've been doing is task shifting, getting away from facilities and doctors to the community members to bring health to communities, that last mile. But what we've also learned recently is we can't just dump everything onto community health workers. Jump and do this, and then do that, and then do this, and then do that, and then do this. So what I said earlier was the need to create a system to support this community health worker. And that includes what we've started to roll out are community outreach workers. So these are lower trained, but well paid to actually deliver meals or food to families, so that the community health worker continue to do community-based but community health work. They're trained at a certain level. So we just have to be cognizant of the amount of task shifting that we're doing, and to really invest in the entire system around a community health worker to ensure it's both sustainable and effective. It still is cost effective to prevent emergency department use or other emergencies. So just want to mention that. Thanks.
Okay, that's a record for longest answer to a question. The next question, any tips for building upon community trust for contact tracing when we are already on the phone and the people we're calling are still distrustful? And if I can just add to that, when they don't trust you seemingly no matter what you try, what are your fallback options?
I'll never forget the first time I met Alexandra in May or June, and she essentially told me that if I didn't get out of the institution and start working outside of institutions, that there would be entire communities left behind. And I think the idea of scaling the communications, not through experts, but through folks we empower and then we put in our place, has been the most successful piece of what I've been able to observe the last few months.
I can pipe in with, as soon as you notice you're talking about them rather than us, you're the wrong messenger. So it just fundamentally challenging any place where we're being incredibly individualistic and kind of abstract about who's making the call. And we have literally just begun to do that in the United States. All the other countries that are knocking contact tracing out of the park, the thing they have is that they had community healthcare workers already in place in communities, in neighborhoods, at the neighborhood level. So it will require us to rethink, how do we connect the kind of domain expertise that Mark has with the domain expertise that Alexandra has, and that the organizations connected through Cure Americas has, and see them all as different kinds of domain experts that have to be at the table. We really have not started doing that, I would say.
Mary, just to build on that, I think so much of this work is about building empathy and about connecting to our core humanity. I saw a comment from Jeff in the Q&A around calling and receiving no information and sort of feeling bad, right? I think the provocation here could be, how might we reimagine this system so it feels like you're calling a friend, or so you're starting a friendship or a conversation and you're not being interrogated, and you don't feel shameful. It's sort of, what is the opposite experience, and how do we begin to create that?
And just to add to that, a lot of techniques for this kind of difficult communication environment may be things that work sometimes. They may work often in some situations and not as often in others. So no one's promising perfection, just these are strategies to fall back on and to attempt. We have a comment from Wade Schuett, who it's kind of profound. I'm not going to read the whole thing because it's pretty long, but he's talking about how challenging it is with decreased funding, with some of their public health frontline workers feeling possibly even threatened in certain environments. That's a little bit of a different flavor to building trust when they see you as the enemy. Do you guys have any thoughts on that?
This is Andrew, and we are coordinating with public health, local health departments in the state. And I think it is both from behind the scenes policy and investment requirements, because you're right, Wade, that public health has not been invested in, and we see the fruit of that today. And so it is through partnership. We cannot work in silos. And so when the public health department of fill in the blank county invites the church and their CHWs to partner with them at their staff meetings and figures out how to overcome the HIPAA challenges and all of the regulatory challenges, that's when that we can reach the people who need it the most. It's through really this innovative thinking at the local level that's happening in Durham and many other counties. It is happening, but it does require a leadership and investment, and that's where we do feel lucky at North Carolina.
I would just add to that. I mean, health is inherently intersectional, right? All of us who work on and study the social determinants of health know that it overlaps so deeply with economic prosperity and mental health and physical health, and how we are engaging with our families, etc. And so I think there is an opportunity in this moment. I know many of you on the call work with organizations that are not directly health providers, and yet you are here and yet you are engaged in this question. So I think really taking a more expansive view on how we put all of our resources towards serving the needs of people that include their health, but also include the other acute or more chronic needs that they may have.
I just want to jump in for just a sec on this as well. I think there are lessons from the early days of HIV that could be brought to bear here in terms of building robust community engagement and partnerships with community. The programs that were eventually launched in HIV/AIDS were really built upon models of engagement around community planning groups, around care and prevention planning, around the Ryan White planning councils that were created. And all of those mechanisms were really designed to have health departments working hand in hand with their community partners to bring affected communities to the table, to, sort of bridge differences, to really take a holistic approach. And I think some of those things that worked so well in the early days of HIV maybe have fallen off the table, or maybe are not as applied robustly across all the areas of public health. But certainly now is a time, particularly as we're launching into vaccine campaigns, to start to really engage in a robust way between health departments and communities and bring back some of those models that I think served us well in the past.
Okay, and Julie, you might see there there's a question directed specifically to you. So while we've got the focus on you, as you mentioned, states have shifting communication needs, and for a variety of reasons, contact tracing might not be chief among those at the moment. Is there an opportunity for states to take advantage of the ad space on offer by Facebook or by any other service that is offering such resources for content that was created outside of the process you described?
Not at this time. So at this time, we're testing this coalition model of creating these assets around contact tracing and making them available to all states. And that's our lane right at the moment. Now, we certainly have proposed that we would like to go further. We would have loved to be able to do the same kind of work around other mitigation strategies. We'd love to embark upon some work in this around vaccine acceptance. But we're not there yet, and we need to get additional resources to be able to pivot and broaden the focus beyond contact tracing.
Okay.
This is Meredith. I'll just make another plug for our communications toolkit for health departments. So within that toolkit, we have draft social media messages, public service announcements, graphics that you could quickly pull and use on your own account. So that might be an option if you wanted to look at that.
Looks like we're running low on questions. So if you guys have any more questions, we still have 11 minutes. So it's now or never to enter your questions. Now make it a flood of questions.
Jonathan, can I speak to a point that was just made? Because I just would kick myself if I didn't say this out loud on the call. That for community organizations, I think you can get so much out of using the materials that Meredith was just mentioning and that Julie, you all are working on, and using them as a template to then refine. And sometimes that means tearing it entirely apart, but it gives you a starting place. I just want to caution everybody, for the research that I do on how people take up information, share information, I have a set of colleagues who study misinformation and disinformation, particularly around political communication. And it's probably not surprising for me to say out loud, social media is not necessarily considered the most trustworthy source. So people still, if anything, our radar is up, our guards are up. And I would just caution all of us to realize that when you're using ad space, it's both free and it comes at a cost down the road, which is most of the companies are using that data to be able to inform other decisions they might make. And that means their energy isn't necessarily on, well, how would I make sure a messenger is matched with the message to get it to somebody who will listen? So I would just implore everybody to keep remembering the messenger, to Julie's point, really matters as much, if not more, than the message. My early days were doing HIV canvassing at queer bars in San Francisco. I was a queer youth activist. And so it mattered a great deal that I was entering those spaces as somebody people recognized as not the public health department. And holding on to that truth that we all know is going to be so critical for the work we do ahead.
Thank you. Jeff Stark made a comment that I think is worth commenting on. When he called, he received no information. They just wanted to know who he was in contact with. It was hard to remember everyone, and the times when you felt bad. It was kind of hard to answer those questions. Is there a way to work around that kind of fundamental problem?
So here's the best use of technology would be that you're just using it to prompt your memory. Like, wouldn't it be amazing, and it's entirely possible today, to be able to take a contact tracing app, a notification app, a proximity notification app, and be able to open it up with a community healthcare worker who can basically see what's on your screen and walk through where have you been the last 2 weeks. Because mostly when you're frazzled, you need somebody to help you think through, like, oh yeah, my kids were playing with these other kids. So that could be one of the most valuable uses of these technologies as information sharing tools. But they've literally been built to not do that. So I hope we think about repurposing some of these technologies for getting information shared more effectively.
And at Cure America, another thing that we're really pushing is cultural competency training for contact tracers and community health workers, even frontline community health workers, even myself. We all have biases, right? We all have these psychological blocks. And so to remember what Michelle was saying, the humanity and the empathy and the lack of judgment. So it's a combination, like you said, Jonathan, these are not perfect tech strategies, but it's a combination of the right messenger, the right message, the right training, the ability to listen and empathize so that no one feels judged. If someone called me today and asked me where I was this morning, I'm like, I have no idea where I was this morning. How am I going to remember 2 weeks ago, right? And so it does require sustained commitment to evidence-based practices to reach communities. The evidence is there.
I will tell you, I don't remember where I was an hour ago.
Jonathan, I want to unpack the trusted messenger idea a little bit. And this is something else that Alexandra told me early on that I would love for you to speak to, Alexandra. Before I started working with you and the folks that you introduced us to, you told me at one point, like, you need people like Yvonne, someone who's not on this call, but somebody who is one of our community health workers. And you told me, if Yvonne says something is good, people will listen to him, that it is good. And we need to be working with him. So you brought him into the meeting, and now I follow him on Facebook. He posts something, he gets 3,000 views, 5,000 views. Why? Why do you need somebody like Yvonne to be sending that message, Alexandra?
You know, I think that we have to grapple with the context and history. You know, for many of our families, navigating the health system has been a challenge. So anybody who represents and works in the health system, you know, there's been that work over the years, right, to try to have like cultural competency, to have language access. You know, for websites. I mean, how many of our websites that you look at are accessible to families? So when you have somebody like Yvonne, when you have somebody who has come up and has shared struggles, shared stories, I think that's the empowerment. That's the piece that is super powerful, because they're like, well, you know, you share this story with me, like you know what it feels like, you know exactly what are some of the constraints and all the different things. And it's like, and these people who are invested in community, who continue to learn and continue to share what they know. I think there's reciprocity happening, as you know, as folks like Yvonne, folks like the organizers that have been doing this work, grassroots organizers for many years, you know, they're sharing the information that they know, and people know what they're about. And they've seen them do consistent work, consistently, you know, doing the work, being there for people. Like, you know, before the pandemic, think about what relationships thrived on. I mean, they thrive on, you know, bonding, and the folks at the health department and public health are doing a lot of work that is beneficial to communities. But we need to have these connectors, these influencers, these people who can, you know, get access to the information and open doors, become bridges, essentially. Yvonne is a bridge. I'm a bridge. There are many people in the community that are bridges. And I think that is the best bet that we have with folks who are trusted, folks who understand the complexities, and can speak, can have that ability to speak to institutions, but also, talk about some of the real-time constraints that communities are facing.
And to follow up with that, Alexandra, what you're saying is that you were there before. You were there during, you picked up the phone call in the middle of the night. No matter what the need was, these connectors, these organizers, these trusted community members were there. Unfortunately, a lot of us work 9 to 5. I don't know about you, I work 7 to 7 or whatever it is, but the office is closed, or I can't help you with that. You don't have documentation, or all these barriers. But Yvonne was there, and so he's trusted. And so that's why in 3 months, Cure Americas, with 180 community health workers who were trusted, has reached 70,000 people. In 3 months, from nothing. There was nothing before this, and it was built up. It was what they were already doing. And so it's not because public health isn't there as much as it's because these trusted communities are, and they will be afterwards. They're going to be there after us. Why are we competing with them?
Okay, we're getting pretty close to the end here on time. So I will let you know, Mark, that your this visit by our surprise guest star, your daughter, was very popular. So many like her. And that's it for the Q&A now. Back to you, Angela.
Thank you all. And as we were going through this, I was like, wow, and wow, and wow. So for me, I appreciate you all taking time out to be with us today, to spend the time on this webinar. And everyone who's called in, we want to thank you for attending. If you have a question, it may come up later that you may not have gotten addressed today, or it's an after question, please reach out to us at epic@cdc.gov. As a reminder, today's presentation has been recorded, and you can earn continuing education credits for your participation. Please follow the instructions found on emergency.cdc.gov/epic. The course access code is EPIC1209 with all letters capitalized. And again, I want to thank everyone for being with us today. Please enjoy the rest of your afternoon and this season as we go through. And remember that we are going to come out on the other side. Thank you and have a good afternoon.